All good? All right. If you're still looking for seating, there are a bunch of seats. Thank you so much, everyone, for clearing your stuff off. I know it feels good to stretch out, but this one's going to be a tough one. There are a lot of people in here today. So I just ask that you kindly be respectful. I know everybody's going to be in and out. But just kind of find back into your seats. We are not allowed, just to remind you, since it's such a big crowd, that we're really not allowed to sit on the floor or matriculate into a big pile in the back. It's a fire hazard, so I'm sure if you've done it at some point, somebody said, can you please go try and find a seat? That's our job. So, if you need any help or if you need anything, there's lots of people with these little red things on their tags. We can help you with whatever you want. You have some interest, you need some follow-up, just let us know. All right, raise your hand. You get the Groupio thing? You all get it, right? Okay. Who's actually given feedback on there? I like you better. Thank you. Thank you. We really encourage you guys to get into that and give us a lot of feedback. We do read it. Our presenters ask for it, or we send it to them. It really does interest us what you think about each presentation. Let's see. This afternoon, right after here, head this way and make a left. We have a poster session. Raise your hand if you're new and haven't been to the poster session. Okay. Wine and cheese is served there. Okay. It is a cash bar, but just letting you know the good details. Sorry about those watching this on webcast. Next time, hopefully we see you here. Okay. My boss is not going to let me do this again. All right. So let's get into the finer details and get started. This is session 53, Clinical Practice, Escape Avoidance Hierarchies, Occupational Therapy Procedures, and Self-Control. And our speaker, and who I'm very excited to introduce, Dr. Ed Blakely. And he told me I'm not allowed to read his bio. It's online. He said it. All right, enjoy.
Can you guys hear me? You're okay? Okay. How many of you guys, last time I was in this hall was about 3 years ago. I talked on behavioral pharmacology. How many people were there at that talk? I think I'm wearing the same outfit. Right? Right? I had a sinking feeling as I walked in the hall. I think I've been here before. I think I'm wearing the same outfit. So I recycle about every 5 or 10 years, so maybe next time I'll wear something different. Here's what I wanted to do today. I want to talk a little bit about clinical practice, and want to talk more specifically about some occupational therapy procedures, not how you might think I'm going to talk about this. I'm going to talk about some of the behavioral mechanisms that we think maybe are operating when you use sensory integration. And I'm sure most of you guys know about sensory integration. Maybe you do it. Maybe you've seen it done. Amy McGinnis-Stangl was a student of mine, and she's an occupational therapist and a BCBA. And as we were planning her thesis, the question came up, how do these sensory integration procedures work? Behaviorally speaking, do they have behavioral properties? Are they reinforcers? Are they maybe aversive to kids? We don't know. So we're going to talk a little bit about that. We're also going to talk about something that's really near and dear to my heart, and that's something that I call the escape avoidance hierarchy. It's not a technical term in the field. I think other people call it something different. But it speaks to how do we convince kids and adults to participate and tolerate major medical and dental and safety-related procedures. How do you do that? So we're going to talk a little bit about that, how we approach it in our clinic. Time permitting, we're going to talk a little bit about self-control. This session is about 2 hours, so hang in for the next couple hours, 15 minutes, something like that. If I get to self-control, I'll try to. If not, I would rather spend a fair amount of time making sure that people see how maybe some of these OT procedures work. And this whole escape avoidance hierarchy, we've got some videos to show. I really want to kind of work through some of these things with you guys and have you guys have a chance to ask questions and make comments and so on. Okay, having said that, let's talk occupational therapy. Occupational therapy involves a lot of skill development in a lot of different areas, and those of you who are OTs know this. You're probably much more skilled at this than I am. So activities of daily living, education, work, leisure, play. There's also this procedure called sensory integration. What is that? I didn't know what that was, but Amy kind of educated me on what this was. Sensory integration involves presenting sensory stimuli. Typically, it can be based on time. It can also be contingent on problem behavior to kind of calm the kid and get the kid grounded in a sense. That's my understanding of how this is done. Procedures and materials, what's that look like? We've got swings, weighted vests. There's a brushing procedure that's used, balls, mats, blankets, those kinds of things. Here's some pictures of those materials. So here's a weighted vest. That's what that looks like. Here's kind of a smock-looking thing you can envelop the kid. Here's a papoose kind of a thing where you can wrap a kid up. And quite honestly, I've experienced some of these things. It feels pretty good. It feels pretty cool. The one on the bottom is interesting. This is a brushing technique that is, I think, called the Wilbarger protocol, in which you do rapid brushing on the kid's limbs, sometimes associated with joint compressions. And the OTs that trained us on how to do this, because we tested this out informally years ago, got to do this every couple of hours during the day. So these are some of the procedures and materials that are involved in sensory integration. And this is based on an assumption. The efficacy of these procedures, if they are effective for a particular kid, is based on an assumption. And the assumption is this, that problem behavior is a function of abnormal processing of sensory stimuli. That's kind of the assumption. Ergo, what if that assumption is true? If that assumption is true, ergo, if you present stimuli throughout the day, the assumption is that will improve processing of sensory stimuli and therefore result in changes in problem behavior. Now, that may be a lot of assumptions, but that's kind of the assumptions as far as I can tell. Again, I'm not a trained OT person, but from what I've read and what Amy has explained to me, that's kind of the logic to it. All right, so however, that's not what I'm going to be talking about today, is the traditional way of implementing sensory integration. It's the question that has interested me for several years. And the question is this: do the sensory integration procedures have any kind of behavioral effects? Do they have any kind of behavioral functions? Are they forms of reinforcement? Are they forms of negative reinforcement? We don't know that. What happens when you present these stimuli contingent on problem behavior? What then? Does it make problem behavior better? Does it make it worse? All those things I think are important, because in the practice of these things, in the implementation of these things, sometimes these procedures are contingent on problem behavior, sometimes they're not. So we asked the following question. This is Amy's master's thesis. We asked the following question: do sensory integration procedures function as reinforcers? So, very simple question. That was her master's thesis, and we made it real easy, real simple, real easy to follow. This was published, by the way, in Behavioral Interventions, so you guys can read this if you want to. So we started off the procedure, the study, by first doing a preference assessment. We did a multiple stimulus without replacement preference assessment, so we arranged all these sensory stimuli, had them pick one, experience it, and then pick another one, until we got down to the end of the array of sensory stimuli. And we picked the top one. We picked the most favored, most preferred form of sensory stimuli. And by the way, these involved deep pressure. So imagine sensory stimuli involved deep pressure, squeezing, wrapping up in blankets or mats and those kinds of things. So a lot of the data here, you're going to see deep pressure being used. The general procedure involves something called a reinforcer assessment. So for those of you who are not trained in this particular field, let me kind of explain how this works. What we're interested in doing is we're going to have two shapes set up. We're going to have a triangle and a circle. If they pick a triangle, then a sensory activity will be programmed. If they pick a circle, free time will be available for a particular amount of time. So that's the general procedure. It's a reinforcer assessment. This is called a concurrent schedule. Concurrent meaning these two shapes are presented concurrently at the same time. Here's your baseline procedure. The baseline procedure looks like this. So in baseline, Amy and her team presented these two shapes concurrently, simultaneously, and said, pick one. So you present a triangle on one side, circle on the other. Pick one. If the kid picks a triangle, he gets free time. If the kid picks a circle, he gets free time as well. So we're just interested in getting the kid in kind of a rhythm and determining, is there any kind of preference? Is there any kind of bias towards triangles versus circles? I don't know. Do you guys have biases? Do you guys like triangles better? Circle? I'm kind of a triangle guy. I don't know. It turns out that some of the kids did have pretty strong preferences. Then we assigned stimuli to shapes, and this varied across kids. So for one kid, maybe the triangle was associated with sensory activity. Maybe the other kid, the circle was associated with sensory activity. But we assigned each one to a shape for each kid. It varied across kids to start the experiment. All right. Then what we did was, and this is kind of neat. This is a procedure I learned in the lab. Part of my graduate training, I worked in a lab. And I ran pigeons and rats and those kinds of things. So you learn things in the lab that sometimes you don't learn in the applied arena. One of the things I learned in the laboratory is if you have a concurrent, if you're giving a kid a choice, you have to expose the kid to the contingencies for each choice, particularly if they have biases. So what Amy would do, what the experiment would do, would present one stimulus at a time. So you present a triangle, and then you get the sensory activity, and then you present the circle by itself. Kid touches the circle, and they get free time. So we had several of these trials, I think 10 per session, at the beginning of each session. And why are we doing that? We're doing that so that the kids are exposed to each contingency associated with each shape. And that's really, really important. We're doing concurrent scheduling of stimuli. After each trial, you go back and you do 10 of these and at the beginning of each session. Then we did choice trials. So after the forced exposure trials, then we did choice trials, where the experimenter presented both shapes, same time. So imagine you're the kid, you're sitting at the table. Experimenter presents two shapes, one circle, one triangle, and you pick one. If you pick the triangle, you get the sensory activity. If you pick the circle, you get free time. It's a simple choice. Now, that all seems pretty simple, doesn't it? Now it's going to get worse. Now it's going to get more complicated. Because now we're going to do something called a reversal, a contingency reversal. In a contingency reversal, the triangle now is associated with a sensory activity, and the circle's associated with, the triangle's associated with free time, the circle's associated with sensory activity. That's called reversal. You're reversing the contingencies associated with each shape. And you're going to see why we need to do that. Then we have, now it gets even worse, a contingency reversal. So now we're going to go back to the original configuration. The triangle is associated with the sensory activity. I'm just making it up here, so bear with me. The triangle is associated with the sensory activity. The circle is associated with free time. So that's really important experimentally because we want to be able to conclude with confidence that is this sensory activity a form of reinforcement. So you have to have certain kinds of controls and conditions to kind of sort out and rule out alternative explanations. And this is going to be maybe your first term that I want you to learn here today. If you don't already know this, it's called confounding. How many of you guys know confounding, a confounding variable? Some of you guys know it. Some of you maybe have not heard this. We're going to go through this. So, you guys should be skeptical. That's kind of part of science. No matter what field you're in, you should be skeptical about things. If the triangle is associated with sensory activity, and the kid picks it, let's say they're really into triangles, they pick it. And aren't there two possible explanations of that? Number one, maybe he likes the sensory activity. Number two, maybe he likes triangles. Is that possible? That's called a confounding. So by presenting the sensory activity contingent on picking a triangle, you've introduced a potential confound. Does he like triangles? Or does he like sensory activity? We don't know that. Well, we've got to figure that out. How do you do that? You do a reversal. We're going to reverse this so that the circle now is associated with sensory activity and the triangle is associated with free time. So if he starts going for the circle, are you convinced? Is he really going for the sensory activity? Probably, unless he had some kind of momentary preference shift to circles. Is that possible? It's possible. It's unlikely. So what do? You do the contingency reversal. You go back to the original configuration here, and if the choice behavior tracks the sensory activity again, it's very unlikely that he's having shifts in preference between shapes. That's called a reversal, and you're eliminating the CON word, the confound. The two things were confounded. It turns out they did not confound the results. that really what's happening is, and you're going to see the data, that their choice behavior was tracking the sensory activity, wherever it was, whatever shape was associated with it, that's what they chose. So this is our first kid. This is Logan. As you can see, there's 3 kinds of data points. One is circle for circle choices, triangle for triangle choices, and squares for no choice. So in Logan's case, if you guys can see that, he started off by not responding. He had no choices. He was just sitting, hanging out, having fun. Now when we set up the choice procedure, the triangle was associated with the deep pressure, the sensory stimuli. What did he do? He started picking the triangle. Then, when the contingency was reversed to the circle was associated with pressure, what happened? Start picking circle. Then, when it was reversed all the way again back to triangles, he started picking triangles. So for this kid, for Logan, his choice behavior tracked the sensory activity. What's that mean to you? This sensory activity is a form of reinforcement. He's going for it. This is a reinforcer assessment of the concurrent type. Let's look at another kid. Now we've got, I think, Bennett. Yeah, Bennett, he likes, first condition, he's a circle guy. He likes circles. That's okay. In experimentation or a study like this, if you have a bias, you want to see if you can reverse that and change that bias, change that preference to the other shape. So he's got circles. We're going to make the triangle be associated with the pressure. Now, this took a while. I think that there was some kind of medical problem, I believe, maybe a sore in his mouth or something. It took a while to resolve. Once that got resolved, you can see his choice behavior became sensitive to the sensory activity. He started picking the triangle. When we then reversed it to circle, what happened? Start picking the circle. No big surprise. Reverse it back. Now he's back picking the triangle. So again, the choice behavior is tracking the contingent application of the sensory activity, in this case, some kind of deep pressure. So this is an example of a reinforcer assessment. They seem easy when you read these things in books, text articles, but these can be a little bit on the daunting side sometimes because you've got to have all these controls. You've got to rule out other kinds of, what's that CON word? Confounds. Yeah, you got to rule them out. Carter, same kind of setup here. He preferred triangles. He's kind of a triangle guy. I can understand that. Circle associated with pressure, start picking circles. Triangles associated with pressure, start picking triangles, and same thing with the circles. All right, so what do you make of this? We got 3 kids. All 3 kids showed evidence that sensory activity in the form of deep pressure was a form of reinforcement. That has implications. Think about the implications of that. Well, number 1, these activities are behaviorally active. They are not inert kinds of procedures and stimuli. They have behavioral effects which are important to consider in programming. These are potential positive reinforcers. In these 3 kids, they were indeed positive reinforcers. It's easy. So what are the implications? You can probably think of a couple. Could we use these for reinforcers and acquisition programs? Yeah, we probably could. Should we be careful about presenting these things after problem behavior? Yeah, we should. You need to be careful about that. In fact, you might want to avoid that. We're going to follow up with another study that kind of really addresses that issue, but you want to be careful about this because these things are behaviorally active. I think that's the main point for today. These procedures have behavioral functions. So it's important to kind of keep those in mind. What happens if they're used to calm problem behavior? What happens? Well, that's the second study. This is a follow-up that Amy did as well. We have an interest in this kind of thing. What happens? The results of this study begs the question, does it not? What happens if the sensory stimuli are presented to kind of calm the kid? Sometimes that's how they're used. Sometimes they're used contingent on problem behavior to kind of calm the kid. And maybe they do calm the kid. The question that we wanted to raise was, gosh, would they really reinforce this behavior? Is it going to make it worse if we do this? So therein lies the question. This is a study that has been written up and submitted to American Journal of Occupational Therapy, or we've started the submission process, rather. So let's get set up here. And the concept of confound is going to come back again. So mark my words, you're going to learn more about this. All right, so the first thing we did was, gosh, we picked a couple kids. What's the function of their problem behaviors? What do we have? So we started off with a brief functional analysis to kind of set up what's called a pairwise, and you're going to see an example of this. So in a brief functional analysis, what we're going to do is we're going to set them up and we're going to give attention in one condition for problem behaviors for 15 seconds. So that's one component. Then we're going to try the demand condition. We're going to present a task, provide prompts as needed. If they have problem behavior, we're going to terminate the task for 15 seconds. We have a tangible condition. We're going to have tangibles available. If they engage in problem behavior, we provide the tangible for 15 seconds. We have sensory activities, which is unique. We program sensory activities to be available or contingent on problem behavior. Because we're interested in, gosh, do you think that sensory activities could actually maintain and be kind of resulting in or causing problem behavior? There's also a control condition. That's kind of the nirvana condition where everything goes great. And there's lots of toys, attention every 15 seconds, no demands. That's what we all strive for. When we all strive for nirvana, that's what we're trying to get. And then there's a alone condition. There's always an alone condition, or typically there's an alone condition. You put a person in an empty room and count the number of target behaviors. The idea is if they have problem behaviors in the alone condition, it may be maintained by automatic reinforcement, self-stimulatory kinds of behavior. All right, then this is a setup. So keep in mind this is a setup for pairwise. So here's the results of brief FA. As you can see, the only behavior we saw was in the demand condition. Now, this is only a single probe kind of a feel to this. If we had extended those conditions out, would we have seen behavior in the other conditions? It's possible. We don't know that. But this is meant to be a brief probe to identify potential functions to study further. So in this case, Bryce, we're doing an FA on yelling, which is vocalizations above conversation level. All right, so demand-related behavior. Task escape, presumably. Liam had very similar behavior. His behavior was sensitive to task termination as well. Didn't see any problem behavior in all other conditions. So for these two kids, we've got task escape. Now, that's going to present an interpretational problem, but that's okay. We thought, let's move ahead. We've got task escape kind of behavior we're dealing with. Now let's do a pairwise. So the pairwise is set up very similarly in a sense. You've got two conditions in this case, however. One is demand, the other is control. So we take those two conditions from the brief FA, and then you study them in more detail with more repeated sessions. So in the demand condition, you present the request, provide prompts as needed, contingent on prompt behavior. You remove the demand for, say, 15 seconds, I think it was in this case, yes, and then go back to the task and so on. And these sessions, I believe, were 10 minutes, maybe 15 minutes, I don't recall. Control was the nirvana condition, where everything's going well, everything's happy, toys, attention, no demands. And here's the results. So for Bryce, clearly his behavior has some sensitivity to task escape, didn't have high frequencies of behavior, but there was some sensitivity to task escape, so it looks like his behavior is sensitive to task termination. No big surprise. Same thing with Liam. His behavior also was sensitive to task termination, higher rates in this case, but still the same kind of a message here that his behavior is very sensitive to task escape. Now the fun thing is, now we know what the functions are. We've got an idea about this. Now what we're going to do is we are going to provide sensory breaks. Some of you guys maybe have heard of sensory diets or sensory breaks. It's the programming of certain sensory stimuli according to a certain schedule. And this is what we're going to do. We want to present these sensory breaks contingent on problem behavior, which happens to be task escape. Maybe you can see the interpretational problem that's going to happen here. But nonetheless, this is focused on what we're doing here. So in one condition, we're going to have a contingent sensory break. So every problem behavior gets a 30-second contingent break. Or actually, it's, 30-second contingent break. And the frequency of those sensory breaks depends on the problem behavior. Every problem behavior gets a sensory break. Now, the non-contingent sensory break, this is where it's going to get a little more complex. The non-contingent sensory break is going to be a little bit different. It's going to be contingent on time, not on behavior. So what we're going to have is, and we're going to use something called yoking. Now, in yoking, what we're going to do here is we're going to figure out how often did he earn sensory breaks during the contingent condition. If he earned them every 30 seconds, we're going to program fixed time 30 seconds in the non-contingent. So I'm going to show you examples of this. In Bryce's case, the time between sensory breaks was 35. I'm going the wrong direction here. was 35 seconds. He earned sensory breaks every 35 seconds in the contingent condition. So in the fixed time or non-contingent, how often? 35 seconds. And you'll see the logic here in a couple of minutes. Liam earned sensory breaks every 44 seconds, and during the non-contingent condition, we present them every 44 seconds. So there's a logic to this, and the logic is this, that when you have a contingency between behavior and a consequence, that's one possible mechanism for behavior change. Another possible mechanism is the sensory activity per se. Is it possible that the sensory activities, when presented any time during the day, will have certain kinds of effects on behavior? Could be. So what we want to do is we want to separate out contingency, this, from exposure to the sensory activity by itself. We want to separate those two out because you know what? They're confounded. When you set up a contingency, you're setting up a potential confound between involving the contingency and the exposure to the actual stimulus. Let me give you another example that might make more sense to you. Let's say we're using caffeinated beverages as a reinforcer, potential reinforcer. When the kid completes the task, he gets a caffeinated beverage. If you see an increase in the frequency of task completion, is that a result of the contingency? Or is it a result of the caffeine? Doesn't caffeine make you do more things? Aren't you guys moving around a lot? Helps keep you awake? Helps do your tasks and so on? That is essentially a potential confound. The effects of caffeine are confounded with the contingency between the soda and the behavior. Same thing with sensory diets. There's a potential confound here between behavior and sensory activity, the contingency, and the actual sensory activity itself. We don't know the effects of the sensory activities by themselves. We don't know that. We're going to find that out. So what we really have is this kind of a layout. The sensory break contingent on problem behavior has these two aspects, contingency and sensory break exposure, two at the same time. The fixed time or non-contingent sensory break has only one of those. It doesn't have a contingency anymore. You've removed it. This is based on time. So what we're going to try and do is figure out, is the contingency is what at play here? Is that what's going to happen here? Is this a result of the contingency between this stimulus, these sensory activities and behavior, or something else? Let me show you the data here, and we can maybe sort all this out. The procedure looks like this. It's a flowchart. I've kind of gotten into flowcharts lately. It's easier than text. I don't know if you guys like flowcharts. I've become kind of a visual person as I've gotten older. So here's what we have. At the beginning of each session, 5 minutes of play. Relax, have a good time. Now becomes the fine motor task. That's kind of what OTs do, is it not? That's part of what we do, or part of what you guys do as OTs. You present fine motor tasks and work on skill development. So, present the task. For correct, praise. For incorrect, least to most prompts, praise, and then recycle. However, contingent on problem behavior, what do you have? 30-second sensory break. That's the contingency. This is it in a nutshell, what we did. Do you guys like the visuals? Better than 2 paragraphs of text? It's hard to follow. I find it hard to follow those complex paragraphs. All right, here we go. Here's the non-contingent layout. This is what it looks like. 5 minutes of play, just like normal. 5 minutes of play, hang out, have a good time. Fine motor task then starts. Then, during this whole process, correct gets praise, incorrect gets least most prompts and praise, and so on. But here's the difference. Now, instead of earned sensory breaks, we present sensory breaks based on time. And that time is, this is the Y word, that time is yoked to how often he earned it in the contingent condition. It's yoked. So we want to know, is this contingency what's happening here? Wait till you see the data. It's pretty compelling. When sensory breaks were earned, contingent on problem behavior, look at the frequency. You're talking about 25 or almost 30 times per session. It's a lot. You spend a lot of time in sensory break. Look what happened when we presented these things under a fixed time schedule. Behavior went down precipitously. We represented it. Sensory breaks for yelling, again. Behavior increases. And then presented it non-contingently, it went down. What's that telling us? The contingency is what's operating here. The contingent application of a sensory break after a decel, after a target behavior, reinforced it. That has clinical implications. Really, really important clinical implications. This is Bryce. Liam going to have the same look. Going to have the same look. In Liam's data, he had chin hits. That was his target behavior, his problem behavior. As you can see, the frequency of chin hits was between, 18 and 26 or something during the first condition, where they were contingent. Sensory activities were contingent on chin hits. Frequency of chin hits went down precipitously to 0 during the non-contingent condition. Recovered in the next condition here when they were contingent, and then when they were non-contingent went down to 0, essentially 0. All right, so what do we have? Well, we've got some, what I think are kind of important conclusions here. Number one, for this particular study, sensory activities contingent on task escape behavior function as a reinforcer. That's the obvious one. It wasn't the exposure to the sensory activity, it was the contingency. The sensory activity, the sensory break, functions as a form of reinforcement. What was the mechanism? Is it mere exposure? Nope, it's the contingency. It's functioning as a form of reinforcement. Now, taken together, our future research, let's talk about the interpretational issue first. Interpretational issue is this. It's this confound problem again. The sensory breaks are confounded with termination of the task. And there's a visual here if you guys to kind of look at. For problem behavior, two things happened. Number one, task was removed. Number two, a sensory activity was presented. Is that an interpretational problem? Yeah. Which one was it? Was it termination of task, or was it presentation of the sensory activity? Or was it both? We don't really know that from this study. But you know what? When in talk with Amy about this, it didn't really matter to us. We didn't really care. We could do this. We could study this in the future and sort this out. But what we wanted to do was study something that sometimes happens in OT protocols. And sometimes what happens is sensory breaks are presented contingent on problem behavior. The fact that these behaviors were maintained by task escape makes it kind of an interpretational problem. It's hard to know which one it is. But that was okay for us because we just wanted to know what happens when you present sensory stimuli contingent on problem behavior. In this case, task escape. It doesn't make it better. In this case, it got worse. Future research, we could try and sort out these two mechanisms. We could definitely try and sort it out. We could also ask the question, what if you present sensory diets contingent on attention-maintained behavior or tangible-maintained behavior? You could do that if you wanted to. What about other behavioral functions of sensory activities? Aren't there other behavioral functions here? Is it possible that sensory diets could be a form of negative reinforcement? Do you think kids, those of you who do this, have you seen kids who really try and get out of this? Yes? No? Yes, sometimes, yeah. We did some informal assessments probably 10 years ago, and we found some kids went for it, some kids avoided it like the plague. So think about this. Here's another angle on this. Let's say that these sensory stimuli are aversive. When you present them on problem behavior, what would be the likely outcome of that? Problem behavior is going to go down. Yeah, maybe not for the reason that we might think. It just may be simply parsimoniously thinking, maybe a form of punishment. Not that we're trying to punish kids with this, but knowing the behavioral functions, knowing the behavioral valences of these stimuli is really, really important from my point of view. Are there other behavioral functions? Yeah. Could these stimuli serve as establishment operations? Possibly so. So from my point of view, I think it's really helpful if we take some of these sensory integration procedures and really study these and catalog some of the potential behavioral effects they might have. I think only then can we make really good decisions about how and when to use these techniques. By the way, gosh, using these as potential reinforcers would be a reasonable thing to do. If they like them, why not? Why not have these kids earn some of these activities? Who doesn't like to have some deep pressure? It feels pretty good sometimes, I think. I think a lot of kids find that to be pretty cool. Okay, one more thing about restraints. One of the things that was kind of the bane in of my professional existence, probably about 15 years ago, was I worked with some kids and adults who were self-restrainers. I don't know if you guys have ever worked with these kind of kids who like restraints. And that's been baffling to me over the years. How is that possible? And why does that occur? There are hypotheses about why that occurs. There's several of them. But one of them could be that if we know that certain sensory stimuli, such as deep pressure, have positive reinforcement value, is it possible that kids like to be restrained because They just like deep pressure kinds of stimuli. And what better way to get restrained? What's the best way to get restrained? Do you guys know? You guys pretty good at this? Self-injury. Aggression. Take your pick. Self-injury is particularly compelling. Who doesn't want to stop someone injuring themselves? Property destruction might work too. Yeah, all of the above. So we had kids. I had kids in my caseload years ago who were big-time self-injurious kids. And we found ourselves restraining them more and more and more. Now, looking back on those cases, because of going through this experience with Amy and her colleagues, I'm starting to think, wow, I wonder if this is really a deep pressure kind of phenomenon. It makes it interesting. Yes, ma'am?
Can you tell me if in the sensory release it was delivered by another person? So was the sensory stimuli delivered by a person?
In this study? Yeah.
Or was it something they accessed?
Well, I think it was a little bit of both. They could, some sensory stimuli was delivered, some they could access it on their own accord. So it's kind of in the moment. They could pick whichever sensory stimuli they wanted to pick.
So there could be attention.
Yeah, there's other confounds. There could be attention confounded with this, yeah. But that's okay, because from our point of view, all we wanted to do was
Look at what's actually occurred.
we wanted to replicate how this is done in some OT protocols. Sorting out all the confounds. You got the confound thing going. Yeah, there's a lot of things going on when you do these procedures. Those are studies for future research. All right, questions? Questions about that? Let's take some questions. Any comments, questions? That was a good question, by the way. Any questions? Anything? Yes?
Is there a reason the sample sizes were so small?
Yeah, well, in behavioral research, that's kind of how we do it in behavior analytic kind of research. We study small numbers of folks very, very intensively. You probably ask about, what about a between subjects design? That could be done. That could be done. The issue with between subjects, and that's maybe a topic for another time, the issue with big groups, and I've done group type designs, sometimes it's hard to tell how many responders and non-responders there were. You have to look at the individual data, because all you're reporting really are means and standard deviations. But we need to have more research on this. This is not the end all. This is just kind of a beginning stage. This is how you could maybe start off by studying some of the behavioral mechanisms of sensory integration. Anything more? Tom. Tom Freeman, ladies and gentlemen. Pardon me?
The third condition, sensory break, continuing on crowd.
Yeah.
I noticed that the rates were way down when you did the yoke version of the sensory break, and that was yoked to basically the non-contingent version rates were way down.
Yeah.
Did you do a control condition where there were no sensory breaks at all?
No. No, we didn't. Yeah, the question was, did we do any conditions where there was no sensory breaks at all? We didn't. That kind of condition, though, wouldn't sort out the confound between contingency and exposure. And that introduces even a more complex confound. So these types of reversals, I find these very helpful to sort out that issue. Because if you didn't have any sensory breaks at all, then you're removing contingency and exposure both at the same time. So that's kind of why we did it this way. Experimentation is hard enough to do. It's not easy. And you never really answer all the questions in any given study. Research is like building the wall. I've heard this metaphor being used. Research is like building the wall. Each study is a brick in the wall. And as you do more studies, you can draw firmer and firmer conclusions about things. Okay, anything more? Anything more? Yes?
Clarification.
Yeah.
When you did the fixed time sensory breaks, you got that number for the fixed time from what contingency, like what?
Back here. Yeah, we figure
I
out.
don't see the arrow, sorry.
Let's see. Oh, I don't have an arrow here. Let me use this thing. Let me try this out. How about that? Okay, yeah. All right. The time they received, say, fixed time 33 seconds or something. How do we get that? We got that from how often do they earn it here in that condition. That's how yoking works. This is called within subject yoking. Your non-contingent condition is yoked to this condition.
I just wanted to.
Okay, anything more? Yes.
Sensory break, did you use what you want or they were exposed to a variety of
They had a choice of a variety of things. They pick what they want to do in the moment.
Sorry, can you repeat her question?
Yeah, the question was a good one. Was there only one sensory activity, or did they have a choice among several activities? Had choices. Okay, if there's nothing more, let's, how are we doing for time here? So we're doing okay. We're about 45 minutes in, okay. All right, let's go on to, yeah, we did questions. All right, here's another kind of a thorny problem, I think. And that is, if we're serving kids and adults, I assume you guys are serving one or the other or both. We're working hard, serving our clients, trying to do the best we can. It turns out, and this is no major surprise here, that kids and adults tend to avoid unpleasantness. I think you guys do the same thing, do you not? Who wants to go in for a root canal? You don't do that in your free time. I don't know anyone who's ever done that. It just doesn't happen. So we can do that. We can put things off. We can forget to make an appointment with the dentist. Do you guys ever do that? Subtle avoidance. It's all right. Nothing wrong with that. The issue is this, though. What happens if we have some health and safety related things that these kids or adults need to deal with, need to be exposed to, need to participate in? How do you get them to do this? How do you get them through this? It's not an easy thing. And we have some examples. I'm glad to introduce Joy Bennett here, who's a project manager for us at our clinic. She oversees a project in health and safety. And this project is really set up to deal with this very problem. How do you convince kids and adults to participate and accept these kinds of health and safety related procedures? Here's some examples. 25-year-old female who's not had dental care since early childhood. You're going to see her. I've got a movie. You're going to see. What do? She's got 4 bottom teeth that are loose, ready to come out. What do you do about that? How do you do that? We got another one. What about a 25-year-old female who never had an OBGYN exam? Never had one. How do you convince her to do this? 11-year-old male never had dental care. We're working with him right now. A 7-year-old male with ear problems requires surgery who will not tolerate anybody touching his ear at all. Runs away. Has tantrums. And he's got to have surgery. What do we do about that? 12-year-old male, we treated this guy many years ago. He needs frequent blood draws because he has frequent surgeries. He's not buying it. He's not having it. How do you do this? How do you convince him to cooperate with this when you're talking about needles, withdrawing blood? How do you do that? It's a daunting, kind of a vexing task. And it's something that has been kind of bedeviled me for years and years. So what options do we have? Well, we've got a couple. We've got several options, actually. One is, how about meds? Can we try meds? Yeah, sure, you can try them. We tend to see kids who have Xanax on board sometimes. It kind of makes sense. Xanax is an anti-anxiety drug. Kind of makes sense. Reduce anxiety, make people more cooperative. Actually, Xanax is a benzodiazepine. I don't know if you guys know that or not. It has anti-punishment effects. So what you find to be really aversive, you may not find to be all that aversive at all when you're on Xanax. I'm not just kidding around. That's actually true. But does it actually work in these kind of arrangements? If you have Xanax on board, will it actually work for you? It's not consistently effective. Then you have to worry about side effects. Those of you who maybe know about Xanax or those related drugs, it affects your memory. If you take Xanax for a couple of days, you may not remember what you were doing when you were taking Xanax, so it may affect your memory. So drugs are always an issue. Efficacy and side effects are always an issue with drugs. What about general anesthesia? How many of you guys know about kids who you serve or adults who end up going under general anesthesia for dental procedures? Yeah, it's kind of how it goes sometimes. What are the problems with general anesthesia? Well, it's very effective because you're really knocked out, and they can do whatever dental procedures or physical procedures you need. But there's always that risk. The risk is much, much lower now. When I first looked at this, probably 20 years ago, the risk was 1 in 20,000 of a bad event, including death. Now it's 1 in 100,000. It's very safe. But you still, if you've ever seen these consent forms, do you ever think to yourself, I wonder if I'm going to be 1 in 100,000? I wonder if that's going to be me. I certainly hope not. So It's not always appropriate either. If you're doing general anesthesia for blood draws, is that really going to work? You can't do it that frequently. It's just not going to work. So we have a task in front of us, do we not? We've got to figure out how do we get these kids to cooperate with these procedures. General anesthesia is one of your possibilities. Another possibility is, and you're going to see some evidence of what this looks like, you can power through it. Maybe you guys as kids maybe had to power through some things you didn't like. People have had oral exams in my classes, when you have to come in and talk to me in my office. Sometimes you just have to power through it. That's the way it goes. It's frightening, maybe even it's terror, perhaps, but you got to get through it. What happens? We have lots of emotional behavior. You get really upset, crying, heart rate increase, all kinds of things happen. You have some risk events, and these things sometimes end up in restraints, do they not? If you really power through some of these procedures, you end up having to hold the kid. Maybe that's the way it is, but we're wondering, are there other ways to kind of avoid that or work through that so you don't have to end up restraining them for every single application of the procedure? Behavioral contracting, that certainly can be part of the equation. Try a behavioral contract. Set up an agreement. Will that work for a relatively extended dental procedure? Yeah, I don't know. We tried contracting with the blood draw kid, earn his favorite thing. It's just too unpleasant. When the moment of truth comes, when you have to put your arm out and have a blood draw, not having it. Could this be part of an effective plan? Sure it could. Sure it could. So it's something to consider. The one thing that I find kind of interesting is this, that I'm just checking on time here. Okay, we're good. So it occurred to me about, let's see, back in the 80s, this was a long time ago, we had a mobile dental guy driving around in a big van. If you can imagine that. He's driving around in a big van providing dental care. He had a nice layout in his van. It's pretty cool. So we had a chance to get some of our kids. I was working at a place called Threshold in those days, and we had a chance to have our kids participate in a dental exam. But here's the problem. The mobile dental unit rolls up. They're not getting in it. Guess what? They're not going to lay down on the chair. They're not going to do anything. They want no part of this. So it kind of forced us to think, what the heck are we going to do about this? And somebody said, I remember who it was, hey, what about some kind of gradual introduction kind of thing? What about that? And we tried it, and by golly, it worked pretty good. It took us several sessions, but we got them accepting the dental care on this guy driving around in a van. It was a real van. I'm not just saying a van. It's a real dental, it's an official dental unit, not just some kind of van. So, and you know where we got this from? You know where this person who made this recommendation, you know where they got this from? They got this from the field of behavioral therapy. Those of you who know anything about desensitization, maybe you guys have heard of that? They had these hierarchies. So that's really where this came from. It wasn't just made up. It came from the field of behavioral therapy. So what they do is they have these hierarchies of feared stimuli. Things that really freak you out, they have these hierarchies, starting with not very fearful to really, oh my God, I got to get the heck out of here, fearful. So, and then they teach relaxation skills. That's what makes it desensitization. It's the teaching of relaxation skills as part of this hierarchy that makes this really an interesting procedure. So let me give you an example. Here's an example of a hierarchy. How many of you guys like snakes? How many of you are completely wigged out by snakes? Okay, hang on there. Okay, all right. I hope this won't be too bad for you. So step number one. So imagine yourself if you're in an office. Step number one, we're going to show you a picture of a snake. Okay, how many of you guys okay with that? Picture of a snake? How about talking about a snake? Can you do that? And there's two possibilities of how to do this. You can do it in real life. I can show you the picture, or I can have you imagine a picture. And therapists do it both ways. Well, the thing is, it's going to get worse now. Sorry. Now the snake's actually going to be in the office, but it's going to be about 20 feet away. So imagine if I had a snake up here. I'm holding a snake. You're starting to wig out maybe a little bit, but you're okay. I'm still 20 feet away, and you're relaxing. If it starts to get too much for you, what do? Raise your finger and say, that's too much for me. I got to get out of this. Then, if everything's okay and you're making progress, do you see where we're headed here? Now it's 10 feet away. So now I'm coming down the aisle with a snake. All right, here I come. 10 feet away. It's a live snake. It's not a large snake, maybe a small snake, maybe a medium snake. He looks scary, though. Sight of snake at 5 feet. You guys see where we're going? It's going to get worse. 1 foot. Now you have to touch it. So I'm standing right next to you. Imagine, use your mind's eye. I'm standing right next to you. I've got a snake in my hand. You got to touch the snake. If you don't want to touch it, it's okay. You can mand to get out. This is your time for a man. I want out of this. That's okay. But you're going to be practicing your relaxation skills as you go through this. Then you're going to touch the snake for 5 seconds, 10 seconds, and so on, until, if you really get good at this, you have another career option. I'm just saying. This is something else from the 80s, man, or from the 70s. This is Alice Cooper. Snakes were part of his show. Did he have a snake phobia originally? I don't know. But he doesn't now. He does quite well with that. In case your day job's not working out, got a lot of possibilities. So once you have this hierarchy set up from least to most unpleasant, now you can then practice your relaxation skills. And if you get really good at this, if you really get good at behavioral relaxation, and there are books out there that will do this, will teach you how to do this, you can really deal with a lot of different things. And this is one of them. So you can learn to relax in the presence of each one of these steps. Okay. What do we do about this now? So how do we apply this to convincing kids or teaching kids to accept dental, medical procedures, other kinds of health and safety? And there's a lot of different applications out there. There's a bunch of them. How do you start? First thing you do, you've got to figure out what your requirements are. You've got to talk to your service provider. So when that mobile dental thing showed up, we had to ask the dentist, all right, what's required here? What do we have to do? What are the expectations? Well, he has to walk into the van, he has to go and sit down on the chair, and he has to lean back on the chair, open his mouth, and allow me to kind of examine him with a bunch of tools. Then he can get the heck out of there. So there's a sequence of steps that's a socially valid sequence of steps that you've got to design. You've got to get these steps right because you want to simulate these steps in a sense or get the person through these steps so they'll be successful in real life. How do you do that? You can interview the provider of services. Can't you talk to someone who's been to the dentist? I think Joy has talked to people and she's interviewed people about how does this dentist work? Or you can do something that you've done. You can look at your own experience with dentists and figure out what skills are required by me at Blakely, what skills are required by me to get through a dental visit. Now we teach it to somebody else. So self-exposure, exposing yourself to this can be pretty cool. And here's an example of a pill ingestion. This is a case we just finished. Teaching a kid to take a pill. He'd never had one. He'd never taken pills his entire life. What do you do if he has a fever? What do you guys know? Do you guys know? He won't take them. Suppositories. Who wants to do that? Nobody wants to do that. That's no fun, and that's hard to do. It's very, very difficult to do. So here are the steps. So imagine, I want you guys to kind of think about what would be your first step? Where would you start? This is audience participation time. You got to learn how to take a pill. What's the first step? And you don't like pills. You know what they are, and you avoid them like the plague. What's the first step? Pardon me? Any kind of pill. Antibiotic, Tylenol. Yeah, any kind of pill. Don't you have to present the pill? Yeah, isn't that where you're going to start? Present the pill. Stay calm, pill goes away. So that's step number one. Tolerate an empty capsule within 1 foot. Now what? Get a little bit closer. Tolerate an empty capsule within 6 inches. And you can go different ways with this. You can go many, many different ways. There's no one way of doing this. Number 3, tolerate empty capsule touching lip. Now we're touching the lip. Now, after touching lip, now what? Think about this. What's next? Got to put it in the mouth. You got to get something in the mouth. You got to try it. So we start off with a half of a capsule in the mouth for 2 seconds, and then allow them to spit it out. It's okay. They can spit it out. It's an empty capsule. No harm done. Next step, empty capsule in the mouth for 5 seconds, and then empty capsule mouth with chaser, where you actually have to swallow it, and then the whole empty capsule. So there are some other sub-steps to this, but that was the sequence we went through. If you go through this sequence, you don't have a lot of emotional behavior because you're starting with something that's very, very non-threatening to the kid. It just seems to go easy. Is there still resistance? Yeah, there still is. So this is an example of pill ingestion. Here's a blood draw example. The blood draw example goes something like this. And this is simulation in the clinic. So part of your hierarchy might start off in your clinic, and then you have the main event at the provider. So here's an example of blood draw. Sit in the chair for 5 seconds. All you have to do is sit down in the chair. Then sit in the chair for 10 seconds. Sit in the chair for 15 seconds. Then you start bringing out the tools. So you imagine yourself, you're sitting in a chair, all of a sudden these tools appear. What are the tools in a blood draw? Needle, tie-off, alcohol wash. Got to have all that stuff here. So you've got to tolerate the presence of these things. And these kids are pretty savvy. They know what's coming, perhaps. They kind of know about blood draws. Maybe they've experienced it. Or maybe it's something weird they've never seen before, and they just don't like it. Next up, sit in a chair with tools. Sit in a chair with the therapist holding tools. Sit in a chair with tools for 1 second. Tolerate alcohol wash for 1 to 5 seconds. And why 5 seconds? Because that's what's required in real life. Alcohol wash isn't about 5 seconds, maybe less, somewhere in there. Then you've got the tie-off. Remember they tie off your arm above the elbow just to get the blood pumping? Tie off for 10 seconds, tie off for 15 seconds to a minute. Then you've got touch the mock needle to the arm. We've got a mock needle. You're not going to have a real one. We're not nurses. We're not doctors. We're just pretending to be. And hold the mock needle to the arm for up to 20 seconds. Now, what are we going to be wearing in all this? What do you guys think? What does a blood draw person wear? Scrubs? Got to have some scrubs? Whatever it takes. You've got it, and you want to do your simulations as close to the real thing as possible so you get generalization. Now, the main event. This is the in vivo main event blood draw process. So imagine what's going to happen. We're going to take the person into the office. We can still do some quick trials here. Sit in chair for 5 seconds. Okay, very good. Then you can escape. And you'll see some of the procedures that we're doing for this kind of thing. Tolerate the nurse holding tools within 6 seconds. You've got to have a blood draw person who's cooperative, who can allow you to take breaks from this, because that's what we're going to be doing. That's what you're going to be seeing here, contingent breaks. Tolerate alcohol wash, tolerate tie-off. And then, of course, the real main event, you've got to tolerate the needle going in. Now, think about the logistics of this. What do you do about this? You just allow the person, just hope. Are you training and hoping here? That the kid's going to put their arm out and go for this? You kind of are, but what do you always have in your back pocket? If you have to hold them, if you have to restrain them, then are you going to do that? You have to kind of make that decision. How vital is this blood draw? If it's really vital, you might then use the restraint. But here's the choice you set up for the kids in that case. The blood draw is going to happen. Would you rather be restrained a little bit, hold their wrist or hold their arm, or do it on your own? I don't know if you guys have had experience with this, but if they don't like to be restrained, that's a winning combination, because then they're going to say, if I have to do this anyhow, I think I would rather do it on my own. And most of the kids we've treated, that's kind of how it goes down. They would rather do it on their own than have to be restrained. I mean, who wants to be restrained? Most kids don't. A few do, but most kids don't. All right, questions? Questions? Yes?
So obviously with our clients in terms of, I work very hard to prepare myself for reinforcement, gain instructional control. So in our center, the kids are going to let me shine a flashlight in the house and pick up art. But going to that novel setting with a brand new person, that just adds a whole extra set of variables. How can we program better for that?
I'll show you. Yeah, I've got a couple thoughts on that. There's no perfect system, though, because you're right. Don't they know that I think something bad's going to go down here? We're just playing around in the clinic. We're having a good time. When you see people with real masks on and real scrubs, holy smokes. It's a game changer. But there are some techniques, we call them common stimuli, that I'll show you on video, show you on film. Yes, sir?
What do you call it? You just said common stimuli?
Programming common stimuli. Yeah, I'll show you an example of that. You're going to see it on film. I've got 2 films to show you guys. I'm guessing that you guys kind of have an interest in this. How many of you guys do this kind of work, this health and safety kind of work? Yeah, it's a big deal, is it not? It's a huge deal. We've got to get this figured out. Now, yes?
Sometimes it seems like the longer you delay it, like having lots of steps, it makes it worse. Just because of the brain by your building.
It could.
It's almost like it's better to just not even tell them you're gonna have it done, and all of a sudden you'll lose it, and then they're out.
Well, yeah. Okay, yeah, the issue, I think, if I can paraphrase your question, is it better sometimes to kind of power through? Go quickly. Through the steps, you mean? Yeah, we don't linger on these steps. These steps go as fast as we can go. So that, you're right, to avoid this kind of, we're just putting off the inevitable. So one of the cases I'm going to show you, the bulk of the work was done in 3 sessions. We got through all the steps. The dental procedure was a little more involved. You'll see. Okay, how about this? How about if we take a break? Yeah, let's take a break. Stretch your legs, get a caffeinated beverage.
Thank you. Sorry about that. They don't have a microphone, so I'm going to go spend some time.
Okay. Thank you all for coming back. It's nice to see you again. All right. The main event here is about ready to happen here. I'm going to show you guys some videos, and we can kind of work through these cases. I had some really good questions and comments during the break, and just to prepare you, we're not going to teach relaxation to these kids. These kids probably don't have the skill repertoires to really benefit from that. And the relaxation was really more for the behavior therapy kind of intervention, where you've got a typically developing adult that he or she can learn relaxation skills and apply them. With these kids, it'll be a hard thing to do, but you'll see the procedure and how everything kind of lays out. So, welcome back to the. I believe this is the matinee show. I think on Wednesday afternoon, we got another hour to go, but I'm going to really focus on some of the procedures in this whole hierarchy kind of thing. Before I do that, let's talk about data collection. What kind of data do you collect? Well, you can collect all kinds of different data. You can make video records, which we've done. We typically do that now, and show the progress of treatment throughout this, and you can kind of see how things play out. You also have data such as this. This is just some mock data in which I believe is percent correct. And notice that we have percent correct for step 1. Then when we add step 2, you've got percent correct for steps 1 and 2. Steps 1, 2, and 3, 1, 2, 3, 4, and so on. So that's pretty easy to do. That's kind of trial by trial data that you guys are probably familiar with to some extent. That's one option. Another option is to do something that looks more like this, which is a little more fast-paced. One of the cases I'm going to show you today, this is how we did it. So we are graphing the step that was completed during a session, and it may look like a cumulative record. It's not a cumulative record. It could go down. Let's say the kid gets worse and we have to go back a couple steps. It could take a dive and then go back up. So this shows steady progress. We also have problem behavior superimposed on here, so you could really record both if you want to. We've had cases where problem behavior really is eliminated very, very quickly. We've also had cases where the problem behavior takes a while to kind of resolve. So let me get my glasses on here. Oh, it's a whole new world. You can actually see. Here's an example of some data collected by Bill Flood and Dave Wilder. They graphed the number of feet away from a parent with a kid with separation anxiety. So the dependent variable here was the distance in feet as they moved through the procedure. So the hierarchy in this case was distance away from the caregiver. We're trying to get the kid to kind of not be so glommed on to the parent. And they're working on trying to increase distance in this case. So they're just graphing the distance as they move through their hierarchy. So there's a lot of different ways to do this. You can make up your own way. Maybe you can think of a better way of doing this. But there are a lot of options here. The basic procedures. Here are the basic procedures. And you're going to see examples of this in the videos. Number 1, you can always provide escape from the hierarchy because the assumption is that these stimuli, this hierarchical presentation of these stimuli, probably function as negative reinforcers. They probably do. You could do an FA to verify that, but the assumption is probably in this case, kids probably don't want to get dental care. Kids probably don't want to get blood draws. So you can kind of assume that. You can also show that experimentally if you want to. Here's another interesting point about this. In some cases, you can't escape from the whole hierarchy. If a kid's in a dental chair, can you say, okay, it's all over and go home? No, you can't do that. So we found something very, very helpful. You can escape to a previous step. So if a kid's on a dental chair being examined, they can go sit in the dental hygienist chair for a small break. If a kid is laying back in the dental chair, you can have them sit up for a small break. So we found that to be very helpful in the moment because it's just not possible sometimes to have a kid just say, the hierarchy's over, I'm going home. Once you get far enough in this, it's just not happening. Your contingent breaks can provide or can involve preferred items. You can always do that. You've got prompts as needed. You've got guidance, verbal prompts, gestural prompts, physical prompts if you need them. You can use the high probability command sequence to kind of initiate the sequence, like do this, good, do this, good, and so on. And then hit them with, okay, put your arm out. Now, is that always going to work by itself? Don't know. But you could use that as one of your tools. You can also model. You're going to see some examples of modeling. It turns out that some kids respond well to that. I think they're exposed to the fact that nothing bad's going to happen here. Sometimes it's fear of the unknown. And you see a model, maybe get their ears checked. You're going to see an example of that. Nothing bad goes on. Maybe it'll help. So we've got a whole variety of procedures that you can combine in your clinical practice. What about extinction? Extinction, as you guys know, is withholding of a reinforcer that normally happens after behavior. You can do, in this case, escape extinction. You can require the kid to perform the step before you allow them to escape. That can be kind of difficult sometimes, but sometimes it works fine. You can also do something that we're very interested in, that's non-contingent escape. Isn't it possible to provide non-contingent escape every, say, 3 minutes a kid gets a break, no matter what's happening? Also, in non-contingent escape, or non-contingent presentation, that might involve some form of escape extinction. If problem behavior occurs, it won't pay off, but it's based on time. So no matter what happens, they're going to get a break after a certain amount of time. You may get less emotional behavior for that. Can you also teach requests or commands for escape? Sure, you can do that. You can also use differential reinforcement. If they man to get out of this, if they request to get out, you can have some reinforcement, some break from that. If they kind of gut it out and get through the technique or get through the step, you can give a larger, more valuable form of reinforcement for that. So differential reinforcement can be your friend here. All right. Let's go on to, here's some references. I'll post this PowerPoint up on the website. I added these a couple of days ago, so if you have downloaded the PowerPoint, it won't be on here. So there's a bunch of different references up here. There's references about needle phobias and a high probability request sequence, blood injury injection phobias, and so on. So there's a fair amount of research on this now for you guys to kind of look at. All right, here's our first case. His name's James. I was going to give you a fake name, but his name's on the video. So just realized it, oh my gosh. So he's the kid who requires ear surgery, and he hates to have anything near his ears. Now, we had the doctor kind of check him out. Is there any medical reason why we shouldn't teach him how to tolerate something, an otoscope or something in his ear? No, there's no medical reason why we shouldn't be doing that. In fact, he really needs to know how to do this. Because prior to his surgery, the doctor's got to look in there, or the nurse has to look in there. So problem behaviors that we have, running away and the dreaded tantrums. Here's this hierarchy. I don't want to go through a lot of details on this, but you can imagine how this is going to go. It's going to be sit on parent lap, watch a parent model, get ears checked. So we've got modeling, we've got tolerating the model, and we had a mock otoscope, which was kind of lame. It was like a tongue depressor with a little thing on it. But it worked okay for us. You'll probably see an example of it. I was not the manufacturer on that, by the way. So we've got mock otoscope going all the way through here, and then at some point, why is that going back and forth? Your head has to move to follow. Then at some point, we're going to introduce the real otoscope. And at some point, he's going to have both his ears checked for 10 seconds. All right, so let's check out the video. Let's see if this works here. Is this going on? Yeah, this is not looking good here. show here.
James, look at your ears, okay? Can we look at your ears?
Wow, this is not good here. Oh, okay, there we go.
You're licking James's ears.
And Mama's here.
No, James's.
I can't stand it.
Okay, ready? Okay, buddy. I'm gonna look in your
How's that?
ear. I know, sweet pea.
Whoa, 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 whoa.
Okay, see? You want to try?
No.
Look, videos.
Very good. Now we do James's ears.
And now Jimmy's is no.
All right, so that's powering through. That's the baseline part of this. You know, I'm trying to get this thing to work here. I guess it has to be over here. So that's our hierarchy. Before we start on treatment, yeah, could you maybe ask those guys if there's a way to fix this? That's odd. All right, so you can that's baseline. So you can see that's the restraint part of this, and that's how it went. The person doing the exam was a nurse, and she supervised this whole process because you've got non-medical people using mock otoscopes. It's not ideal. So the nurse was kind of watching this and making sure that this was done the right way, trained her staff how to do this. It's not that hard, but just make sure. Okay, so let's see if I can
Listen,
do
we're gonna
this.
face mom. You're gonna watch mommy.
Watch mommy.
Mommy's ears.
No, Mom, James here.
Do a 10 count. 10, 9, 8, 1.
Oh, nice job.
3, 2, 1.
Awesome. Now it's James's turn.
Sit down, please. 5, 4, 3, 2, 1.
Awesome
Oh,
job.
that was great.
All
Good
right.
job.
James' turn.
Sit down, please.
5, 4, 3, 2, 1.
Beautiful.
Good job.
All right, mom's turn. Here we go.
1.
Very good.
Beautiful. James's turn.
All right, ready? 5, 4, 3, 2, 1. Awesome. James' turn. We're gonna touch.
5.
1. Did it. Touch. 5, 4, 3, 2, 1. There.
1. James's try.
We're gonna touch.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Very good.
3, 2, 1. Okay.
Right.
James with the pretend otoscope. Now,
All right, so what's happening here? Yes.
Would your intervention be different if he was in pain? If his ears, he needs surgery, but if his ears were in pain because that's why he needed surgery?
Yeah.
Would your intervention be any different as far as what you would be doing?
It depends on why he's in pain. If it's really sensitive, I don't know if we'd be doing this, quite honestly. But this is just more of a discomfort, and maybe it was a fear of the unknown. I really don't know. So here's the deal. So what happened, one of the participants asked about what happens when you get to the real event? Because it's different than the clinic. You can practice all these things in the clinic, and you get to the real event, what happens? One of the things that we're doing is programming common stimuli. So this counting thing, the counting is very, very portable, I think, as you might say. And notice that she's either counting down or counting up. The counting can go with you. So when you get to the real event, you can do your counting. What kind of functions does the counting have? Well, presumably the counting has some kind of condition reinforcing properties. It's always good to get close to 10, or if you're counting down, it's always good to get closer and closer to 1. 1 sounds really good. You like 1? And there's also kind of a discriminative effect of this, because when you're counting, the kid kind of knows mentalistically that escape is coming. So counting, we find a lot of value in counting Number 1 for its condition reinforcing value and discriminative value is also, it's very portable. So your question about what happens when you get to the real event, common stimuli are part of this. Take the counting. When I show you the dental part, we're counting with this gal all the time through the dental procedure. We're doing lots of counting to help. Does that always solve it? No, it doesn't, but it can help. Okay, let's keep rolling here.
10, 9, 8, 7, 6. It's okay.
Okay,
5.
let's try again.
Let's try again.
Gotta keep our hands down.
Hands have to stay down. 10, 9, 8, 7, 6,
6,
5, 4, 3, 2, 1.
There you go. All right, other
2,
side.
1.
Okay,
James.
now it's James's turn. We're gonna touch.
1. Just one touch.
Ready? Hands down.
Hands. Try again. Hands down.
I want different.
Hands down for
I
1.
want different.
We're working for break.
I want different.
Okay, we're gonna touch.
It's okay. Hands down for 1. Breathe. Hands down for 1. Just 1 count.
It's
Look at mommy. Hands down for 1. You can do this. Watch. Look, watch mommy. Look at mommy.
Touch. 1. Now it's James's turn.
We're working towards Tonka here. Come on.
no.
1.
All done. Good job. Mommy's next year. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Just one touch.
1 touch. Ready?
1 touch.
1. So much. We're gonna touch.
5, 4,
No.
3,
No.
2,
No.
1.
There you go. James's turn. We're gonna touch for 5. 5, 4, 3, 2, 1.
1. James's
All right,
turn.
now James's turn.
We're
We're
working
gonna
for
touch.
Tonka. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Good job touching.
9, 8, 7, 6, 5, 4, 3, 2, 1. Excellent.
job. One more side, and then
one
it's
more
time to
side,
go
and then we can go
home.
home. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Okay, now the nurse is on the scene. So the nurse is going to be doing this, and you'll see a little bit of a change in behavior.
Dada's
perhaps.
turn. Look at me. James, look
It's
at me.
okay.
Dada's turn, then your turn.
And your turn, Daddy. 1, 2, 3, 4, 5.
Okay, now count. Listen. Okay, count.
1, 2, 3, 4, 5.
Fantastic.
Good job.
Look at, now watch when it goes in.
1,
Look.
2, 3, 4, 5, 6, 7.
You want to go to 7?
Yeah.
Okay, now count.
1, 2, 3, 4, 5.
Wow.
Look at Claire.
10, 9, 8, 7, 6, 5, 4.
Let's try again. Let's go 4, 3, 2, 1.
James.
Ready? We'll do 4, 3, 2, 1. Ready? Ready? Put your hand down.
James.
Put
Just,
your hand down, buddy.
James. Hey.
5, 4, 3, 2, 1. Very good. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. James is awesome. Here.
Right here.
Right there. Yep. Ready? Right here. 9, 8, 7, 6, 5, 4, 3, 2, 1. Good. You did.
All right.
You did. Great. 9, 8, 7, 6, 5, 4, 3, 2, 1. And we did. What do you want me to do first? You pick.
Ears.
Which one?
Ears.
Just either one?
Yes.
Start with this one?
Yep.
Okay, are you ready? You're going to be very still.
Yep.
We're going to count to 10.
Yeah.
Okay.
1, 2, 3, 4,
5. No pushing.
6,
7.
7, 8, 9, 10.
Awesome.
Great job.
You did great. Okay, let's do this side. Ready? No pushing. 1,
1,
2, 3,
4, 5, 6, 7, 8, 9, 10.
All right. Gonna take a break.
Is that
All right, recap. Okay, so that's the story of James. We haven't gone to the next step yet. He's got to go see the doc, but we think that we're going to do the exact same thing. Now you might wonder, how long does this take? In his case, this occurred over the course of about 3 days. Were there a lot of trials? Yeah, there were. But one of the interesting things about this is there's no history of escape for inappropriate behavior with our staff or with the nurse. And the other key element of this, which I think will speak to your concern, you had a really cooperative nurse. So we're looking for doctors and nurses who can do this. We found that to be a game changer. One of the guys who had dental treatment, the doctor was willing to do the counting, and it made a huge difference. So we like the counting because it's very portable and it's easy for the caregivers to provide that kind of input. Okay, next up. Here's the next issue. The next issue is this. This is a young lady, 25 years old, never had dental care, or had dental care since she was a young child. And the daunting task in this case is she's got 4 very loose teeth that need extraction, apparently, and she has lots of problem behaviors, lots of resistance, hand biting, arm biting, those kinds of things. So very resistant, pretty strong. So what do you do about this? Well, remember your options. Meds didn't really work well for her. Power through it, you'd have to hold her down. And I don't know how safe that is. General anesthetic, probably so. That's probably where she's headed. So we were tasked with this case quite a few years ago in our clinic, and we had approximately 25 to 30 sessions to get this figured out, paid for by MedWaiver, the MedWaiver program down in Florida. So we had to do some fast thinking here and trying to figure this out. All right, so the hierarchy, you can probably guess we developed a hierarchy. There's a lot of steps here. I don't have to go through all the details here, but the hierarchy involves steps in the clinic, in our clinic over here, and then down here, we've got steps down here in the actual dental visit. And the worst part of this, the odd part about this whole dental thing is the hardest step. What would you bet would be the hardest step in all this? Follow-up. No, not follow-up. You might think that. Laying back in the dental chair was the hardest thing for her and other kids we've had. Yes, Joy? There's something about that. I'm sure all you guys have been to the dentist. Do you find that to be kind of scary, you're very vulnerable. You're going back, all of a sudden you see the ceiling appear, and all of a sudden all these faces show up. That's a daunting kind of an experience for a lot of our kids. So, and adults, she's a young adult. So we spent a fair amount of time on this. So let me just play this video. I'm going to close out all this and see if maybe this video will play properly here. Yeah, that's weird. It used to be over here. I lost it. There's hand biting, a little bit of head banging.
Okay, Jennifer, give me the bag. Give me this, Jennifer. Jennifer, stop. No, stop biting. No biting, Jennifer. Stop biting.
Okay, so we have some past escape here. Wouldn't you guess? There's lots and lots of escape behavior. That's the set of steps. We've already been through that, so you probably won't need that to make sense out of this film.
That's right. Nice putting your
We're going
feet
to
up.
pick this
Hey,
up.
head back. Head back. Thank you. Mouth closed. Do this. Good girl.
We're picking this up partway through the hierarchy. So the first set of steps you can probably guess is, let's get her to sit down in a chair. Let's get her to sit down in a chair for a period of time. Then we start introducing some of the tools and some of the procedures. So we're picking this up farther into the hierarchy, probably around the 6th or 7th session, I believe. And she's working on this sitting back thing. You're going to see something over her nose. This is kind of a, you might say, a lame attempt at mimicking the gas, because we talked with the dentist and they said, we're going to give her gas to help her relax, and then we can do our work. So we had to convince her, number one, to wear this thing on her nose. And what else do you have to have when you have gas? Don't you have to breathe through your nose? So you're going to see Wendy, she's the therapist here, she's going to be doing a lot of work on do this. That's what she's trying to do, trying to get her to breathe through her nose. So if she gets exposed to the gas, then that opens up the door to a lot of different things. We can do Novocaine, we can do clean, we can do extraction, all kinds of things. So that was, from our point of view, that was really, really important because we knew what the dentist wanted to do. We asked him about this. That's the whole social validity thing. Make sure we know what's happening and what's going to be required.
Mouth closed like this. Good. Now, close your mouth. Ready? Do this. 1, 2, 3, 4. Do this. Not yet. 5, 6, 7, 8, 9, 10. Do this. 11, 12, 13, 14. Do this. Good. 15, 16, 17, 18, 19, 20. Do this. Very good. You're all done.
Okay, having her earn breaks, having her escape.
Close your mouth.
She's got the thing on her nose.
2, 3, 4, 5. Do this. Very good. 6, 7, 8, 9, 10. Keep your mouth closed. 11, 12. Do this. Good. Your mouth closed. 13, 14. Oh, 13, 14, 15. Do this. Okay. Your mouth closed. 16, 16, 17, 18. Good breathing. 19, 20. Do this. Very good. You're all done. Take a break. Okay, ready? Lay back to me. Come here. Right. Yeah. Thank you. Very good. Hands down for me. Okay. Close your mouth. 1, 2, 3, 4, 5, 6. Do this. 7, 8, 9. Good. Keep your mouth closed. 10. Do this. 11, 12, 13, 14. Close your mouth for me. 15. Good. 16, 17, 18, 19, 20. Do this. Good. Good. Keep your hands down. You're all done. Come on. Take a break. Sit. Sit down for me. Right in. Now. Okay. Sit down. Good. Back to me. Oh, we can't go in here. Very good.
All right, so what's happening here? Simulating, this is a simulation thing, simulating what dental assistants do. You've got what kind of things that she's going to be exposed to here. She's got things being wiped in her mouth. She's going to have dental picks, going to have maybe a polisher, all kinds of things, a mirror. So she's got to be exposed to all that stuff. So we have a dental kit that we use to help prepare them for the main event, the real event.
Right.
One of our therapists one year tried to simulate, the suction noises in a dentist, the water running, and they would simulate it by going very kind of lame, but we do the best we can.
Close your mouth for me again. Close your mouth.
Introducing the tools.
14, 15, 16, do this. Very good. 17, 8. Close your mouth. 17, 18, 19, 20, do this. Do this.
That's a fake syringe. It's not a real one. You can get them at Walgreens, CVS.
4, 5, okay, over here. 1, 2, 3, 4, 5. Okay, one more over here. 1, 2, 3, 4, 5. Close your mouth for me. Good. Close your mouth. 1, 2, 3, 4, 5. Do this. 6, 7, 8, 9, 10. Do this. Okay, you're all done. Let's go.
Yeah, sure. All right. Now we're at the dentist's office. Now we're here for the main event. So what you're going to see here is, this is what you were talking about. What happens, the clinic is all fun and games. Yeah, we got that figured out. She started becoming a lot more cooperative. Now she's in the dentist's office. The reinforcer that you're going to see here is she's not going to leave the dentist's office because it's not practical. You're going to see going to her previous steps. You're going to see a lot of examples of that where she gets a chance to sit up from laying down or to go sit on the hygienist chair instead of sitting in the dental chair. So you see some examples of that. Interestingly enough, here's a kind of an interesting phenomenon we learned with this gal, and that was she was better behaved in the dentist's office than she was in our clinic. Now imagine why that is. It's really, really unpleasant in there for her. She wants out of there. And because of our history, she was willing to do anything that we asked her to do. And do it quickly? Yes, so she can get out of there and go home. So that was weird. That was unexpected. We never would have figured that. But that doesn't happen with all kids. But in her case, she was better behaved in the dentist's office. And you'll see some evidence of that.
Good. Very good. Good sitting, Jennifer. Okay, let's count. 1, 2, 3, 4, 5,
Sorry,
6, 7. Yep.
Hold on for a second. Let me start over.
Okay, Jennifer, I'm just going to sit down. Jennifer, you come sit down with me. Come on, Jennifer. Come sit down.
I'm going to try and figure this out here. All of a sudden, it's full screen here, isn't it? All right, so...
Okay, Jennifer.
Sorry, I'm kind of not with it here with the procedure here.
Okay, Jennifer, I'm just going to sit down. Jennifer, you come sit down with me. Come on, Jennifer. Come sit down. Come sit down. Well, I think I've lost it here. So, that's okay.
I can,
Okay, Jennifer. I'm just gonna-
I can tell you that we were able to do several things. And that was, this is how it kind of ended up. She ended up, accepted the gas, had her teeth pulled, which maybe you should be glad you didn't have to see that. Maybe that's okay. She had her teeth pulled. She had her 4 bottom teeth pulled. She tolerated having a Novocaine shot and got a complete dental clean and got a bridge. We got it done in about 28 sessions. So I'll only present this case to particularly for you parents, that it can be done. It doesn't always go this easily. This was a little bit of a struggle, quite honestly, but we got farther and faster than we thought we could with this particular case. But the issues here are, number one, you establish a history of reinforcement for cooperating and participating. But we start off very, very slowly with the first part of the hierarchy. And then we gradually go up the hierarchy as we move through it. So that establishing that history with those first few steps is really, really important. Also, we're not doing relaxation. So let me get the PowerPoint up and going here. We're not doing relaxation, but we're doing the basic procedures that you would use to treat all kinds of things, not just dental phobias and doctor phobias, those kinds of things. Here's a list of applications. I was kind of thinking about this. How many things have I seen it applied to or read about that's been applied to? A whole bunch of different things. Taking pills, dental exams, medical exams, OBGYN exams, hair cutting, food acceptance, church attendance, bar mitzvahs, allergy shots, blood draws, car rides, restaurants, time away from caregiver, toothbrushing, hairbrushing, wearing Band-Aid, wearing socks, wearing clothes, and there's probably a whole bunch of others. You guys have probably maybe applied this to other kinds of scenarios, other kinds of problems. So it has a lot of robustness to this. It's got a lot of traction, I think, for treating all kinds of things. Now, what about some terminological issues? What you're seeing here is the emotion of fear. Are you not? And from a behavioral point of view, this is to kind of give you a little bit of background on this. From a behavioral point of view, specifically from Skinner in Science of Human Behavior, he looks at emotion in the following way. It's a bipartite kind of definition. Emotion being a collection of respondents. So do we have heart rate increase, blood pressure increase, gastric secretions? Probably so in fear. There's also operant behavior. There's the get out of Dodge kind of behavior where they want to get out of there and go home or go to something else. You've got other kinds of escape avoidance behavior, aggression, property destruction, self-injury, all kinds of different things. So we are treating more the respondent part of this. I'm sorry, the operant. We're treating the operant, the escape avoidance behavior, and we're hoping that the respondents follow. Now, in watching Jennifer, we treated the escape behavior. Would you guess that the respondents also were treated? Did she seem more relaxed? Same thing with James. Was he more relaxed after treatment? He seemed that way. We don't really know. So one of the research issues here is we'd like to track and measure the respondent part of this, the part of the anxiety and fear that I think some people complain about, like I feel anxious, my heart is racing. That can be very unpleasant. So we're very interested in, if you treat the operant part of this, the escape, does the respondent also come with it? We shall see. Terminology. This has been called different things. We don't have a real good term for this. As you see in the literature, some studies would call it shaping. Some would call it fading. The behavior therapists would probably call it gradual exposure. I tend to call it escape avoidance hierarchy, or, this sounds ominous, the hierarchy. That sounds scary, like something bad's going to happen, like the firm. I don't know if there's one term that really does this justice, because there's a lot of different phenomena, a lot of different procedures that are involved in this. Aren't there elements of forward chaining in here? First you have to go in the dentist's office, then you have to sit down, then you have to lay back. There's a forward chain feel to this, I think. Is there also shaping? Probably so, because you may accept certain topographies in the initial part of this, not so later. Is there just tolerance training? I suppose so. You learn to tolerate things that are of increasing unpleasantness for greater amounts of time. So there's a lot of different kinds of phenomena going on here, a lot of different kinds of procedures. I just like the hierarchy because I'm used to it. It's a hierarchy of skills, hierarchy of unpleasantness. And there's all kinds of procedures that go along with that. Okay, summary. So what are we doing here? So basically, here's how this kind of plays out. Identify the unpleasant activity first. You've got to figure it out. There's a lot of these kind of activities that kids have to, and adults have to learn how to tolerate. Then develop your hierarchy that's socially valid. Make sure you talk to your providers and figure out your steps that are required in that particular activity. Then you present your hierarchy step by step. We're probably not doing relaxation. These kids, at least that we serve in our clinic, are probably not going to be able to learn relaxation unless it's sometime in the future. We are doing reinforcement. We're allowing escape from the hierarchy or going to a previous step. We're trying to do that. We're also providing preferred items as needed. The whole escape extinction thing is a little bit iffy because sometimes you have to do it, but we would rather not have to do that. Maybe non-contingent escape could be a viable option, perhaps. We've got one kid who's really, really afraid of stairwells. So anytime he goes in a stairwell, he takes off and runs. And we tried escape extinction one time. It was too awful for him. He was so upset, and he's kind of a strong kid. It just didn't work. So we're allowing him to bail out anytime he wants, but we're using differential reinforcement. If he accepts the step and cooperates, he gets more reinforcement than if he bails. And that's kind of how we work it. Okay, any questions about this? I've got a little bit on self-control, and then we're going to call it a day. Any questions? Yes. Reva. Yeah, the question was, can you do any pairing of these tools that these kids don't seem to like with other reinforcers? Just pair things? You sure could. You sure could. There's probably some natural pairing of the tools with escape. There's also pairing with preferred items if you're using those. But you're talking about trials of pairing. Sure, you could definitely, that's a great idea. Other questions? Yes.
I was wondering, does it work on things that have already been very negative? Like, we used to take our 18-year-old to church, and he gets very agitated when little kids are around. So one time he ran up and he smacked a kid. So we're not taking him to church anymore. And even when he's calm, as soon as we mention church, he says, "No, you're going to smack the kid. You're going to smack the kid." Would it work in a case where he already had this high anxiety about doing something again?
Yeah, I think it does. In fact, when we see the kids, they've usually had that kind of history where they're completely wigged out by the whole experience. And they've even maybe had some reinforcement for some of that behavior. They've gotten out of it. So the kids that we see in our clinic, they have varying degrees of history of that. It does make it harder. It does. That, for those kind of kids, don't you want to start off really slow? Maybe you just mentioned church. Stay calm, get a reinforcer. And start there. You're starting way, way back. The question that was raised is a good one. Does this work when the kid has already kind of been exposed to this unpleasant event and have a history of this? Yeah, it can. It usually does. Quite honestly, there's something funny about this. This is probably the most robust procedure that I've seen in my career. I'm jinxing myself here. I've never seen it not work. Not even one time. Does it sometimes require escape extinction? Yeah, sometimes it does, but not always. Other questions? We're going to talk self-control. Yeah. Yeah, like a blood draw? You can't. Yeah, and we're not doing that. A mom came up here, yeah, and she said, "Hey, what about a local anesthetic on the arm?" Not a bad idea. We've never done that. Maybe that'd be something you could try. A local analgesic. But you know what? Here's the thing. It comes down to a kind of a difficult choice, I think. That if you really have to have a blood draw, they've got a choice. You can take it independently, or we're going to have to hold you if you really have to have it. And that's not a good choice. But sometimes it comes down to that. And you know what we find with kids? They would rather do it without being held. And I think pain is kind of part of what happens in life, and you've got to learn to tolerate a little bit of it. Some people have to tolerate a lot of it. Yeah, we're not going to introduce pain. Yeah, that's not something. We introduce discomfort and fear-evoking stimuli, but we're not going to introduce pain. Yes?
Just a suggestion for us. We have a 29-year-old who doesn't prefer a blood draw since he started at 12
people, the butterfly is a big help. And he's 29, they do the butterfly needle. It's so much more delicate to.
Yeah, butterfly needle as a suggestion. Yeah, you guys probably have a wealth of experience at this. There's all kinds of options, and I would recommend take advantage of them. One more question. I'm going to just hit self-control for a couple minutes, and we're going to be done. Yeah.
Have you ever had instances where you have it where you say that they'd rather do it themselves than do the restraint? What about the instances where the restraint is a reinforcer?
It's going to be a problem. The question was a good one. What happens if they like to be restrained? It's going to be hard. It's going to be hard to do that. I guess you're going to end up having to restrain them and do the procedure. That's really what it may come down to. Fortunately, we haven't had that happen yet. But it sure could. It's a great question. All right, self-control. One thing about behavior analysts is this. We've got something to say about everything. Would you guys agree? Maybe it's not always the best thing, but we've got something to say about everything. And that makes it kind of interesting because we can talk about things that are kind of in traditional psychological terms. We can talk about things like self-control. Self-control from a behavioral point of view, the way it's studied in the laboratory, is this. You have a choice between a large and a small reinforcer. Don't you take the large one? Who doesn't? Everybody does. If you have a choice between something small now or something small later, which one do you take? Something now. Who doesn't want something now? You don't want delay of gratification. You want what you want right now if you can get it. And life doesn't always happen that way. In self-control, it's that unusual playing off of those two variables. What happens if you have a large reinforcer, but it's delayed, versus a small reinforcer right now? What say you, ladies and gentlemen? What do you go for? Does it depend on the reinforcer? Probably does. If you're talking about money, you can probably wait for some money. If you're really, really hungry and you've got snacks, Skittles or something, do you want some snacks right now? You might. Depends how long this delay is. So this is the classic problem in self-control or delay of gratification. Does this have clinical implications, practical implications? Yes, it does. It has to do with health-related behavior, since we're talking about health and safety kind of behavior here. What happens in real life? I can have a cigarette now, get a nice bolus of nicotine going in my brain, feels pretty good. It's also an antidepressant, feels great. Or I can have good health. How long does it take to get good health? Months or years. Is it any surprise why people sometimes take up cigarette smoking? Immediate reinforcement. Nicotine is a known reinforcer. But we try and say no. What about, this is a little slow here, alcohol. A lot of people struggle with alcohol. Alcohol is also a known reinforcer. I can have a beer now, have a drink now, or I can say no to alcohol and have a good, healthy life that may take months or maybe even years down the road. It's the classic problem that I think that a lot of people face in real life, and it's a classic problem that some of our kids face because they may have a choice between the straight and narrow, do my tasks, or I can opt for task escape for a minute. Those of you who work with kids, do they sometimes opt for this option? Yeah, unfortunately, we all do. Don't we go down the primrose path sometimes? Yeah, it kind of goes that way. But that's okay, because there are ways to encourage people to take this option. And one way is this is called a technique to facilitate self-control, gradual delay or effort. This is something that's been published several times in the literature. So if you're working on a weighting program or a task program, how do you introduce this so that the kid will opt for the reinforcer you're programming and not for the easy one, the task escape one, in the aggressive kind of problem behaviors? So you can adjust your magnitude, then you can slowly increase your delays until you get a larger and larger, now this is kind of slow here, delay until you have something that's socially valid. So basically, in the self-control literature, two take-home points. Number one, you can talk about self-control from a behavioral point of view. Small immediate versus large delayed. Number 2, there are techniques to facilitate this self-control. When you're teaching weighting programs or task completion programs, you can gradually increase your task size. Many of you guys probably do that. But just know that there's a conceptual framework for this. Self-control business. This is a study that was done back in the 80s. This was after a gradual introduction of delay. And this is percent choices of the larger reinforcer as a function of delay to larger reinforcer. So as the delay got longer, they had less and less choices for the larger reinforcer. This is before training. This is after training. So gradual introduction is a powerful technique for you guys to consider. Okay, I think that's enough for now. Let's see what time it is. Yeah, it's almost 3:30. Any other final questions to wrap up? Anything more? Let's go home. Thank you all.
Thank you, Dr. Blakely, excuse me.
It's okay.
Excuse me. Just a reminder that anyone seeking social work CEUs must sign in and out daily at the registration desk. Please remember that the poster sessions will take place after this in Dean's Hall 1 and 2. And please complete the evaluation for the session through the Groupio app. The session number is session number 53, and the speaker was Dr. Eb Blakely. The code for the session is HOT, as in hot, 874. Again, that's HOT 874. Thank you.
It's okay.